What's going on, guys? Welcome back to the Blossom Podcast. Today we are continuing that interview with Dr. Apel and Catherine. A ton of information yesterday. I hope you enjoyed it as much as I enjoyed, interviewing and having that discussion. So today we are going to pick up where we left off. We were talking about the BMI, and we will be discussing stalls and expectations in terms of weight and rate of weight loss, among other things like the SIPs and feeling tired, macros, gallbladder, all of these things that we discuss in this conversation. So I hope you guys enjoy it. So without further ado, let's kick off that intro.
This is another episode of the Blossom Podcast, your number one source for everything bariatric surgery, from pre-op to post-op. Registered dietitian Alex Conception gives you real, raw tips and motivation through your journey. This is the Blossom Podcast.
But that kind of brings me to my next question and concern that I do see on our groups. I know you get this question all the time. It's kind of a two-part question. The 3-week stall is real. That is a real thing. I want to know why. And at what point, it's so subjective because somebody can lose a ton of weight in the first 2 weeks or even factoring in pre-op diet weight. At what point, knowing the 3-week stall is a thing, knowing we say roughly 10 pounds a month for the first 6 months, where do I as a patient start freaking out saying, I've lost 30 pounds in the first month. Now here I am going into month 2. How do you kind of mitigate those expectations?
You're not stalling, you're healing. Mm-hmm. Okay.
Right.
You just had surgery 3 weeks ago, right? And imagine, and let's just say you lose 30 pounds. Okay. And I say, go to the grocery store, pick up a 5-pound bag of potatoes, and then grab 5 more bags and reflect on how that can disappear from your body in 3 weeks. Mm-hmm. So there's going to be, number one, your resources are limited, you're healing, and there has to be some adjustment, and the body's freaking out. What's going on?
Correct.
What's going on? And you just need to adapt and adjust, and that's what's happening. Yep. And this is also where you can lose inches and not pounds, right? Because contrary to popular belief, the body's number one priority is not fat loss, it's organ function. So with less water, with less nutrients, with all of those things played in this picture, you're going to prioritize what's important.
Right. There's always stalls, but again, the stalls are not a true reflection of you not being in a caloric deficit. The stalls are a reflection of fluid shifts, hormonal changes, the body kind of adjusting its metabolic needs, adjusting its basal metabolic rate. Realize, we did the surgery, your brain, and you know that we did this intentionally. The body is a little dumb and doesn't realize this is intentional and is trying to respond and adapt to what's occurred and try to curb things. Okay? Yes. It thinks, oh shit, here's the period of starvation that I've been saving up all these calories for, and it's trying to not let you burn through your savings so quickly. So it's trying to adapt and slow things down, which is why there's periods of rapid weight loss, periods of slow weight loss. You got to mix things up. So for me, as long as you're sticking to the rule, I don't really care what happens between day 1 and day 30, or between day 30 and day 60 and 60 and 90, because there will be ups and downs and stalls just like the stock market. All that matters to me is the net change over the course of a 30-day period. And so if you're starting at 250 and 30 days later you're at 220, well, you've lost 30 pounds. You've already lost 3 months worth of weight as far as I'm concerned. If you only lose 8 pounds between day 30 and day 60, hey, that's 8. Yes, it's less than 10, but add 30 to the 8, you're at 38, divided by the two months you're on.
Right.
That's 19 pounds a month on average, which is still above the 10 pounds per month average that we seek.
Double.
Correct,
Double.
Exactly. So for me, again, it's rare when someone doesn't shake 60, if they need at least 60 pounds of weight loss, it's rare when someone doesn't shake at least 60 pounds in the first 6 months. Now, if you're starting at 180 and my goal weight for you is 140, well, guess what? You're not going to lose 10 pounds a month for 6 months because you only have 40 pounds to lose.
Exactly.
You'll lose 10-ish for the first month or two, then it'll slowly taper. As you get closer to the goal, the body further adapts and further is reluctant to get all the way there, which is why it can get a little frustrating when you're 10, 20 pounds shy of your goal. You just stick your nose to the grindstone, maybe adapt a little bit and say, hey, I got most of the weight off at 50 grams a day. I'm going to go to 30 for that last little bit. I'm going to make some adjustments. The more you kind of do these little mini shocks to get the rest of the way there, the less the body can adapt. But again, if you've been doing the same thing every day for 8 months, the body knows what you're doing. The body knows what you're going to do with it. The body knows what you're putting into it, and it will adapt based on what it predicts is going to happen tomorrow. But if all of a sudden tomorrow you do completely different activity, you do some caloric restriction, you take some extra calories in, you mix things up, the body will have adapted to the wrong thing, and the weight loss continues.
Great. So I always tell people, your metabolism is a reflection of your lifestyle leading up to this point. And if you're a lot older too, right, this is what the body knows for decades.
Correct.
So it's going to be hard to fight that as well. But the surgical intervention, this tool makes it so it is a lot easier to fight that.
Correct. And again, the bottom line here, guys, is the vast majority of patients have at least 1,200 calories a day requirement for their basic metabolic rate. Sometimes there's the rare individual where it's a touch lower. But again, if you're getting 600-ish, 600 to 800 calories in per day, there's no way you can't lose weight. Okay? Again, if you need 1,000 calories a day and you're eating 600, there might be fluid shifts. Your body might be fighting you. It might not be as fast as you would like because you're only a 400 net calorie per day deficit instead of someone who needs 1,800 calories a day and being in a 1,200 calorie per day deficit. But the bottom line here is, with the diet that we prescribe, with the tiny little stomach that you're going to have, and with the marked hunger perception that you're going to have after surgery, it's unheard of for you not to lose weight. It's the same thing when people tell me, hey, I weigh 330 pounds and I only lost a single pound on the pre-op diet. That's impossible. It is impossible. It just means you weren't doing the pre-op diet well. And that's the same thing with people who say that they aren't losing weight after surgery. It's because they're still getting more calories in than they need, whether they realize it or not. Right. Somehow, some way, you're exceeding your caloric needs.
So the small bites or the tastes or the snacking or the sips of the frappuccinos that you think maybe,
I hear a lot of patients talking about, I cook for my family and I am a constant taste tester. So those add up tremendously, because if you can think about just a ranch dressing, for example, 2 tablespoons will yield 150 to 200 calories. 2 tablespoons.
That's nothing.
Okay? So imagine tasting something that is cream-based. That is going to be, easily 200 calories.
It's eye-opening.
With not very much.
Correct. And again, remember, a slice of cheesecake, you take a bite of cheesecake, you got 100 calories in there. 1 bite. You take a bite of chicken breast, you got 10 calories. So it's also a question of what you're tasting, the caloric density of what you're tasting. And the other thing, the basic thing to realize here, guys, is, and this goes back to how most of food in America is kind of slowly poisoning us, is, human beings are meant to eat the way that most animals currently eat. Our species has evolved rapidly over the course of the last, 2,000 plus years. And as a result, we've got delicious food that doesn't come from nature. You can't find a tree that grows cheesecake. You can't find a tree that has Kraft mac and cheese growing from it and those like little instant kits that you just add water to. The more we deviate from the ideal where we're getting our calories from directly from plants, directly from the ground, directly from animals, the more concentrated and processed things are, the worse it is for our machine. Okay? It's rare when you see animals that deal with obesity because they're still eating the way that they've been eating for thousands and thousands and thousands of years. Hunting, grazing, predator, prey, like omnivore, carnivore, whatever it is. They're burning a lot of calories because they're constantly on the move looking for food. And when they're eating leaves, they're barely getting any calories in, so they can eat a bunch of leaves and still not gain weight. The only time we deal with obese animals is when
humans are involved.
When humans are involved.
Yeah. Speaking of, how's your dog?
He is good. He's on a diet right now, having a hard time resetting his metabolic set point.
Oh, man.
God damn it, I know.
He needs the dog sleep.
Yes, exactly. But that's the key. We deal with obese pets because we give them food that we're eating, and if they're gaining weight from it too, proof positive that it's the stuff we're eating that causes the weight gain, and it causes it in other organisms as well. If you feed animals the way they're supposed to be fed, they should have a nice metabolic set point that keeps them there. And if you look at animals in the wild, again, you don't deal with obese animals. I mean, you could argue a bear gets obese, but it's intentional. It's because of hibernation. It's a part of their programmed evolution. There's very little animals out there living in the animal kingdom that deal with weight problems unless they're getting into human foods or they're becoming a pet for the family or whatever it is.
That's crazy to think about.
Yeah,
It is.
same thing.
Look at your pets, guys.
Yeah.
Are they
Yes.
overweight?
Yes.
Are they getting enough activity?
Yes,
Hard to get walks
exactly.
when it's 150
In the wild.
degrees, though.
You want to see shredded animals.
Yes, exactly.
So I want to touch a little bit on. We've talked a lot about the positive effects of bariatric surgery. Obviously, number one being weight loss, getting rid of some of those medications and things like that. But I think it's important to quickly touch on, in your opinion, what do you think maybe the side effects are? Again, this is a question I see a lot on Facebook groups as far as what could possibly, maybe not complications, but long-term side effects post-sleeve specifically.
Yep. So again, for the vast majority of patients getting the sleeve, what I worry about is if they're going to get some heartburn. Okay? Because when you're going from this large volume stomach that has low pressure, and then you're creating a tiny little high pressure, low volume sleeve, in some individuals that can exceed the strength of the lower esophageal sphincter. And the biggest complaint we get post-op after the sleeve in those that don't have a hiatal hernia repair is, oh my God, my heartburn's worse. But I think it's partly because people aren't as aggressive at the hiatus as they should be. A lot of patients seeking weight loss surgery have a frank hiatal hernia or have a sliding hiatal hernia, and addressing that much further reduces the risk of heartburn post-sleeve. So again, for me, the question here is, do they have a normal hiatus or not intraoperatively? And if they don't have a normal hiatus, got to do a nice tight hiatal hernia repair. Got to do a nice tight chorioplasty to reduce the risk of that high pressure sleeve causing a problem. Beyond that, I got to be honest with you guys, in terms of stricture, knock on wood, we know what we're doing. We've done thousands of these. The likelihood of a stricture is like less than 1 in 1,000. I can't recall having a stricture. I would assume if someone had a problem, they would call up and be like, hey, I got a problem, and I'd know about it. So to my knowledge, we haven't had one. To my knowledge, again, knock on wood, a virgin sleeve, a leak just hasn't happened. But again, it's not that leaks don't happen. It's that with proper patient selection for this program, the likelihood of a leak is like nil.
Right.
Now, don't get me wrong. If you're a 2-pack-a-day smoker, if you're on immunosuppressants, if you're on steroids for your RA or for your lungs or whatever it is, and if you have a poor history of wound healing, guess what? You're going to have you are much more likely to have a problem post-surgery than the patients we let through. But that's why we are so diligent with making sure that you're the properly selected candidate before you get out here. It's not that you don't need the surgery. Again, if you weigh 330, number one, you should stop smoking. Number two, we can try to modify some of those higher risk factors for poor wound healing or a complication post-operatively. But the bottom line here is the vast majority of patients that weigh 330 are willing to take the risk because life sucks at 330. So if someone said to me, hey, you smoke a couple packs a day, you're on prednisone 40 milligrams a day for your rheumatoid arthritis, so your choices are keep living like this at 330, keep being miserable, or do the sleeve, but you've got a little higher risk of there being a problem. I think 99 patients out of 100 would say, fuck it, I'm doing the sleeve because life as it currently exists is not worth living.
Right.
Yes.
But the key here, though, guys, is this. It doesn't mean that you shouldn't get surgery. It just means that you shouldn't be flying here or driving here for surgery in an outpatient setting and then planning to go home. There are, we try to pick the most healthy patients on paper so that they have the lowest likelihood of a complication, the highest chance of success, the highest chance of plugging out of life for 4 days and plugging right back in at home 5 days later. So don't get me wrong. Yes, there are many, 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 many more patients that would benefit from the surgery.
And I wish we could see them all.
Of course. I wish we could help them all. But unfortunately, if you on paper have a high risk for a leak, I can't do your surgery. I can't do your surgery as an outpatient, and I would not recommend you flying somewhere for it.
Right.
Okay? We see it all the time. Patients get rejected here, and rather than trying to kind of optimize things and stop smoking or try to get their immunosuppressants down a little bit, whatever, they go to Mexico, and they get the surgery there, and they have the problem. And then they're shit out of luck because they have a hard time dealing with such a major complication in Mexico. And then when they get shipped back to the U.S., it's a months and months and months long process to get healed up. And then they're stuck with these crippling bills because the insurance companies bulk once you've had your surgery out of country.
Right.
So again, the key here, guys, is there are certain, yes, if you decide today, hey, I want to have surgery, I weigh 330 and I smoke 2 packs a day. Well, can't have surgery yet. Got to work on stopping smoking first. Got to work on getting some weight off first so that you have less need for certain medications that increase the risk of a complication. So there are those that can decide today, hey, I'm tired of struggling, I'm tired of the diet, I'm tired of all the ups and downs, and they're ready to go today because they're not yet that unhealthy. And there are others, same weight, but who've been much unhealthier much longer and who are starting off in a much worse position. And there's some fine tuning to be done before considering surgical intervention.
Right.
So stop smoking, guys.
Damn
Cut out
straight.
some of those
That's
risks
the PSA.
because it will affect your healing, and that's the bottom line.
Correct.
Right?
Yeah. So I do see two common concerns again in these groups, and you didn't touch on these, but I kind of want to ask both of you guys this. Number one, hair loss.
Mm-hmm.
People talk a lot about if I would have known, and it's like there's so much information. We even talk about it. You have a podcast, you've done a video.
Mm-hmm.
Is it inevitable? And should that be something that stops somebody from even considering moving forward with this life-changing procedure?
You know, I don't think in some patients it happens, in some patients it doesn't. It's not inevitable. In those where it does occur, the vast majority of them, after this period of shock and the weight loss that occurs, once things kind of level off, you lose the weight, the hair tends to rebound. It's almost unheard of to lose a bunch of weight, get to your goal, have the hair affected, and not with time have the hair bounce back. Okay? And for the 1 in 1,000 patients where that does occur, I would beg them to answer this question. Would they rather be at 300 pounds dealing with a quality of life that is very, very poor, but have a full head of hair, or 170 pounds, much better quality of life, back to work, back to living your family, back to doing things with your kids, but your hair's taking a hit and it's not coming back? I would think, and I would hope that, like 99% of patients, given that scenario, would choose the latter rather than the former.
Right.
And it's not that it's not going to come back. That's the 1 out of 1,000.
Correct.
Right?
Oh,
and
of course.
also, what are the factors involved with that? And are they making all the check marks in terms of getting all your protein in, taking your supplements, and less stress, all
Correct.
of those things? Stress is actually a huge one that there might not be any other factor involved in terms of the directly related to surgery, but just the stress that's going on in their life as well, but then
Correct.
they associate it with the surgery.
Right. And then the other thing to consider here is, if your dad's bald and your grandpa's bald and you're a guy and you're 62 years old and you're getting the surgery and you're already kind of balding and then you lose the hair and it doesn't come back, well, fuck, that's not the surgery. That's just something that was going to happen no matter what.
Right.
So there are certain things that are inevitable and there are certain things that are not. For the vast majority, especially of younger patients, female patients, your head of hair might take a hit, but it will almost inevitably bounce back. So you just have to bear with it, buy a nice fancy hat for the first 6 to 12 months
Or
post-op,
a wig.
do all of the
Come
stuff
on,
that you're
there's like a
supposed to
whole
do.
thing now. It's
Yeah,
like a whole
again.
thing.
But the bottom line here, guys, is, if you have to choose between a beautiful head of hair and 10 years less of life versus the hair might take a hit for a period of time, but you're going to live 10 years longer, and that 50 years you've got left is going to be more meaningful and have greater quality of life. It's kind of a no-brainer, guys. Yes, having your hair be affected from anything sucks, but there are certain things, if I said to you, hey, I'm going to let you live 10 years longer, you're going to be able to be more active, you're going to be more healthy, you're going to have less aches, pains, you're going to be less miserable for 50 years, but your hair's going to have to take a hit. Are you willing to accept that? Everyone's going to say yes.
Yeah, I agree, 100%.
Interesting. That's good. One other side effect I see that's common, and obviously it's not inevitable, but speak to gallbladder issues post-sleeve.
Yeah, so again, the
Why
bottom
that
line here
happens,
is
who that affects.
if you have rapid weight loss, whether through surgery, medications, pure hardcore diet exercise, when you have rapid weight loss, the flow of bile and the recycling of bile is altered. So when you go from 300 pounds to 200 in a 6-month period of time, the gallbladder is likely to be at least somewhat affected by that rapid period of weight loss, that rapid shock. So the key here is this, guys.
Fat loss.
Correct. If you have a perfectly normal gallbladder, no problems whatsoever in terms of its function, no sludge, no stones, no nothing, it's pristine. You get the surgery, you got about a 1 in 8 chance it's going to go bad and you're going to need to have it removed at some point in the future. Okay? On the flip side to that, if your gallbladder is already a bit worse for the wear, which is common in this patient population / America, then you've got a 1 in 3 chance that it's going to go bad and you're going to have to get it out. Okay. But again, I get in there frequently and I'm like, you can just tell. I know what a perfect looking gallbladder looks like. And it's rare to see a perfect looking gallbladder in a 48-year-old female who's had 3 kids, weighs 280 pounds. I get in there like, oh crap, this is one of those 1 in 3 chances versus you get in there like, oh, that's a great looking gallbladder. It's a 19-year-old kid who's, weighs 220 pounds, hasn't had the weight for that long. Gallbladder's pristine. But the bottom line here is there's been a lot of research as to whether or not taking the gallbladder out is indicated at the time of the weight loss surgery. But by definition, if worst case scenario, you got a 33% chance of needing it out, that means you got a 66% chance of getting to keep it. And taking out all sorts of gallbladders unnecessarily for the 1 in 3 chance that you will ultimately need it out because of symptoms just doesn't make sense. The gallbladder, a cholecystectomy is a pretty straightforward operation, but it's not without risk. In fact, it's riskier than the sleeve. And so what I would hate to have happen, and the reason that bariatric surgery and the bariatric community in general shies away from routine prophylactic cholecystectomy, is because you don't want to have the one patient with a common bile duct injury or an issue that didn't even need their gallbladder out in the first place be that person. So for me, again, guys, if you need your gallbladder out, wait until it declares itself, whether it's before surgery, after surgery, whatever it is. If it ain't broken, don't fix it. Again, you're not going to just take your car to the shop and be like, hey, change my engine. No, again, if your car's running fine, rock it. If your gallbladder's working fine, rock it. Get the surgery, lose the weight, accept the 1 in 3 chance. And if you got to go back in the future, because you're terribly symptomatic, trust me, guys, when you're symptomatic from your gallbladder, you want it out.
Yes, this is true.
Correct.
This is true. It's going to be painful, right?
Yes,
Make sure
painful, nausea, you're miserable. It's just not something that you want to live with. But again, you got a 2 out of 3 chance you get to keep it or greater. So don't expect the gallbladder to be removed at the time of the sleeve, nor the other surgeries. And I think the bulk of bariatric surgeons in America / the world would agree with that statement.
Yeah. And in the scenario where you see somebody who's post-sleeve, let's say 6, 9, 12, 24 months post-sleeve, they have to get their gallbladder out. Does this affect their progress, their weight loss? Is this going to stall them? Is this going to change the way that they have to eat or the plan that we've set forth?
So it's going to be the same in terms of protein and vegetables. The thing is that when you have a cholecystectomy, you have to lower the fat because the bile is going to respond to the fat consumption, right? And the gallbladder itself, it stores the bile. So it's readily available when you do eat fat. So now it's going to be needing to be minimized just a little bit to accommodate for that. But over time, there can be another pouch that kind of creates as well, too, for storing bile.
Well, not only that, it's just that the liver adapts to releasing bile differently in the absence of a gallbladder.
Yes.
So the likelihood of someone having true major fat intolerance post-cholecystectomy or fatty diarrhea or whatever it is really, really low. So again, 99 times out of 100, you get your gallbladder out within a month, you've kind of bounced back to normal, whether pre-sleeve or just in the general population. So again, cholecystectomy is the number 1 general surgery procedure in America. And it's because everyone is big in America, everyone's exposed to shitty food in America, and our lifestyles predispose the gallbladder to acting up.
And the nutrition intervention is still just going to be protein and veggies. And if you do have fat, which you still should have some fat, you can even take a digestive enzyme, lipase or something like that to help break it down a little bit easier.
Correct.
So that's where, and it wouldn't affect your progress either way 6-9 months down the line if you are still following the rules.
Correct.
It's just that you lost a ton of weight that kind of put a little bit more stress on the gallbladder, and you had to get it out.
Yeah. If anything, I feel like if you get let's say you're 9 months out and you need to get your gallbladder out, well, if you're on liquids for a couple weeks afterwards and you have to do a modified diet afterwards, it actually potentiates the weight loss.
That's interesting. That's good.
Yeah.
That's a real hot topic. So a couple other common questions. Again, this is more of a post-op question, but for folks leading into this surgery, considering this surgery, talk to me, and again for both of you guys, hot topic is constipation, because it seems very common post-sleeve. And I also want to talk a little bit about how important supplements are post-sleeve. Obviously much different for a malabsorptive procedure, but let's really only specifically speak to those post-sleeve patients. So talk to us a little bit about constipation. Why does this happen and how to mitigate it?
So constipation not only happens oftentimes on the pre-op diet, but certainly post-operatively, both acutely, meaning the first couple weeks, for many reasons, as well as potentially in the long term if you don't do something about it. So the bottom line here is when you're doing 2 shakes a day and a small protein-based meal, you're not getting a lot of fiber in the diet, you're not getting a lot of roughage in the diet, and there's very little that makes it to your colon that is going to actually make for a nice, formed, soft bowel movement. Okay? So a lot of people complain that the pre-op diet takes a hit on their GI tract to begin with, which is why I implore them to start with a scoop of psyllium husk in the shakes on the pre-op diet to offset the constipating effects of the protein, mostly liquid diet that you're on the pre-op phase, okay? Once you get the surgery, number one, you get general anesthesia. General anesthesia slows the bowels down, makes them be a little bit sleepy for a period of a few days post-surgery, regardless of the surgery. Of course, the longer the surgery, the longer the general anesthesia, the bigger the hit, i.e. open surgery versus laparoscopic, but the more likelihood that the bowels are going to be sleepy for a period of time. That, combined with the narcotic pain medications post-operatively, further contributes to constipation. And that, combined with the fact that you're truly on just liquids for 2 full weeks post-operatively, again, if you do nothing but drink protein shakes, there's nothing to get rid of from a solid waste perspective.
Right.
You urinate out the waste, the liquid waste. You still have some mucus and some digestive byproducts that come out from below in terms of a bowel movement, but you're not going to have a formed bowel movement if you aren't eating solid food. So that's why it's important to artificially introduce fiber and some bulking agents, i.e. the psyllium husks to the diet, so hopefully pre-op, but certainly post-op, to offset the high likelihood of the constipating effects of the surgery. And again, it's not the surgery, it's what you're doing with the surgery. The liquid diet for 2 weeks, the pain medications because you're in pain from the surgical intervention, the anesthesia that was required to get the surgery done in the first place. It's not the sleeve, it's what you're doing to get the sleeve done and how you're eating once you've got the sleeve that creates the constipation.
And then long-term, number one is hydration. Huge.
Yep, for sure.
That's one of the biggest ones in terms of, I'm taking fiber, I'm doing all of this, I'm taking, all of the over-the-counter stuff, and it's not working. But through, diet recall, I want to say 99% of the time, it's the lack of water.
Mm-hmm.
So get that water in, and also know that when you do introduce, like, psyllium husk, whole psyllium husk, that it's going to make things worse if you don't have adequate hydration.
If you're taking psyllium husk and you're not staying hydrated, it's going to cause constipation.
Right.
Yeah. Number 2 is fat.
Mm-hmm.
Okay, so when I say protein and veggies, yes, there's is general, but our body still needs fat.
Mm-hmm.
And when you're not getting adequate fat, even in a small amount, imagine a clogged pipe, and you throw some grease down there, loosen it up.
Yep.
So that's kind of also with diet recall, a lot of times that is what is lacking. So at the end of the day, it's balance.
Correct.
And
remember, from a historical perspective, the way we eat in America / the way people eat in the world, the bulk of, unless you're living in a third world country where you're still eating like most of humans ate throughout human history, a lot of our diet was based on plants for most of human history. And when you're eating a lot of plants, you poop more often because you got a lot of fiber in the diet. When you go to this highly processed foods, or when you go into liquids, or when you're eating just meat, that's not the way that the GI tract has evolved to kind of respond to that kind of diet. So the more you get back to that high fiber intake, either through veggies or artificially replacing it with the psyllium husk, that's the way that the GI tract wants things to be.
And I do understand that a lot of people don't want to, fart a lot, and this has been uncomfortable for me, and I work with people, and so they would just mitigate that some more in terms of adding the fiber and the vegetables and things like that. And it's like where you should have, and you can actually just buffer out a period of uncomfortable, and then the body adapts and adjusts as well.
Correct. And then the other thing to consider, of course, is what kind of medications you're taking on, what your bowel movement frequency was like, and kind of your overall bowel regimen prior to even starting the pre-op diet. If you tell me, hey, I'm always constipated, I have IBS constipation, well, shit, you're going to, of course, have constipation when we're done. It's going to get worse. So, you have to kind of plan accordingly. On the flip side, if you're used to someone with loose stools, then you tend to swing the pendulum a little bit more toward the middle and have more of a regular type bowel movement without much intervention, because you go from loose stools, little constipating effects, now you're having normal stools. But again, if you're used to having normal bowel movements, or you're on the constipated side of things, you got to plan accordingly pre-operatively before you get out here, post-operatively for sure.
That's good. So Alex, talk to us a little bit about, and obviously Dr. Apel chime in as well, but what what are the supplements that you recommend post sleeve? And then let's talk. Obviously, they could be a little bit expensive. There's a reason you like the bariatric formulation. But is this something that people are expected to keep up with forever?
So,
and why?
First thing is, the sleeve is not a malabsorptive procedure. Okay, so you will be able to get nutrients from food, but you are now at risk for, because of that volume. If you're not getting a well-balanced meal, you are going to be at risk for deficiencies in terms of vitamins and minerals. Now, the recommendations I have are based off of the ASMBS guidelines, and I recommend them, but it's not 100% necessary. I just recommend it for overall wellness, for longevity, for keeping things under control, your metabolism under control as well. And that's why I like to push at least the bariatric multivitamin for the sake of the ASMBS guidelines. 2, the 5 that I recommend: multivitamin, calcium citrate, B complex, probiotic, omega-3s, with the exception of the B complex, which is because there are a ton of B vitamins in the multivitamin, a ton of B vitamins in animal proteins and things like that too. Everything else I feel is good, at least for the first 6 months, and I would highly recommend them. I would even recommend them forever, but it doesn't necessarily need to be a bariatric brand. Now, with the bariatric brand, they are accommodating for bariatric surgery, and that is with the volume, with the concentration, because if you were to go to the ASMBS website and look up the numbers, you would need about 3 or 4 of the regular multivitamin to hit 1 of the bariatric. So just to make things a little bit easier, not to mention the size of the size and the chewables. So a lot of people are already horrible with pill taking prior to surgery. It's going to get a little bit more difficult afterwards. So opting for a chew or opting for something that's not a horse pill is going to be a lot easier. And that's my recommendation. Now, when it comes to a malabsorptive procedure like the bypass, the auto switch, SIPs, it is 100% necessary.
Absolutely required.
100%, and that is, I wouldn't advise.
Yeah, no, I mean, there's no way you're going to live a long, healthy, happy life if you have a malabsorptive procedure and you're not taking your supplements. Ain't going to happen.
Yeah.
And the other thing we have to consider here is oftentimes people complain about taking the supplements all the time, taking them forever, and then on the flip side, getting the cost of getting their labs checked. So for me, it's kind of like one or the other. So blanket statement, if you're getting the sleeve, I would at least take the recommended supplements for the first year during the weight loss phase to, again, mitigate the risk of the hair taking a hit, maximize the likelihood that it's going to bounce back, maximize the likelihood that you're in your healthiest position possible, given the restricted diet, given the fact that you're not going to get stuff as much as you need from your global meals and diet and so forth. So at a minimum 1 year, take the recommended stuff. At a year, if you're eating really, really well and you're still doing a shake here and there and you're still eating well-balanced, well-represented diet,
vegetables,
you
and
need
things like that.
to be as aggressive with the supplementation, probably not.
Correct.
But if you're taking them, you don't need your blood work checked as much, in my opinion, because, again, if you're taking your vitamins every day, the likelihood of you being in a deficiency, with the exception of some of the fat-soluble vitamins, is pretty low. So it's kind of like, well, would you rather take your supplements every day and not have to get your labs checked as often, or would you rather get your labs checked frequently to see if your supplement-voided diet is up to snuff? So it kind of, again, there's no perfect answer here, guys. Obviously, taking all these vitamins every day with a sleeve, for years and years and years and years, the data doesn't necessarily pan out with it. But I would certainly recommend, again, the first 12 months, plus or minus, depending on how often you're willing to get your blood work checked. If you're religiously getting your blood work checked on an annual basis, you could see what not taking the supplements does. And then at a year, you see, hey, I got to take my supplements. Or, hey, my diet is enough. Everything's cool. Between my diet and my shakes, my levels are normal. And again, check it next year. Again, check it next year.
Yeah.
There are plenty of people who don't take their supplements, but they get their blood work every year.
So in other words, what I'm hearing you say is it would be ill-advised to not take any supplements and not get routine blood work and
Correct.
come here, have this surgery, make that investment,
Yep.
and then just say, well, everything's fine.
Yes.
Correct.
So really what you're saying is make sure that minimally year for the supplements that you recommend, and thereafter, as long as you're doing that routine, maybe twice a year blood work
Yep.
to make sure that things aren't deficient, you
Correct.
feel okay with that.
Correct. And again, with the sleeve, because it's not a malabsorptive procedure, assuming that your intestines are absorbing things normally preoperatively, the likelihood of running into a symptomatic deficiency is pretty low if you're taking your supplements for sure. But again, it also just depends on how restrictive your diet is. If you're eating the same 3 things every single day for years, and those same 3 things don't have a well-represented makeup of vitamins, trace elements, minerals, and so forth, you're going to have a deficiency without the supplements. On the flip side, if you're eating a bunch of different colored veggies, bunch of different different animal proteins, taking a protein shake on a daily basis, you're getting everything you need through your diet.
Right.
Yeah, or even just throwing a greens powder in there too. Not to supplement the lack of vegetables, but to add to it because the volume is still very low.
Correct.
That's good. Yeah, I like that. So we have gotten a ton of questions on the post-op group, all surrounding these couple of different bullet points. Regain, getting back on track, maintaining. What if I didn't capitalize on that for 6, 12, 18 months? Can I make up for lost time? And really, people have really kind of just come out and said, well, I have self-sabotaged. First of all, I'm glad that they're taking that responsibility, but now they're saying, how do I get back on track? And we've talked a lot about, again, the honeymoon period of 6 to 12 months. It's important. So we talked, and the importance of that, we went back to the metabolic set point and the whole science behind that. Talk to us a little bit about, if you feel like you sabotage that first 12 months, can you make up for lost time? Really, I don't know a better way to put that.
So again, it boils down back to the metabolic set point, guys. If you start at 250 and a year out from surgery, you were as low as 160, but whatever happened, life, like shit hit the fan, whatever, and now you're back to 190 at 12 to 18 months. In my mind, you should accept the fact that your set point's at 190, and that's going to be where it's pretty easy to stay, neither gaining nor losing unless you're doing something crazy in either direction. It's basically you're starting, you've used the sleeve to get your set point to 190. 190 is where you can reasonably expect to stay. Now, it's the same thing as without the surgery. If you diet aggressively, you can lose weight from 190 back to 160, but your set point's still at 190. So as long as you keep dieting aggressively, you can stay at 160. The moment you kind of go back to normal, body wants to get back to 190. So for me, trying to further reset the metabolic set point after 18 months is not going to happen. Just like you couldn't do it without the surgery in the first place.
Right.
Now, don't get me wrong. If you're starting off at 300 and you're a few years, you got down to as low as 150 and now you're at 170 and you're a few years out from 170, hey, 170 is still a hell of a lot better than 300. The ones that I worry about is where you're starting off at 300, you got down to 160, and then 5 years out, you're back to 300.
Right.
Again, your set point is not where you want it to be.
It's like you pushed it back.
Correct. Again, you can deviate the set point up. Remember, the body wants to survive. The body erroneously thinks that the more calories it has in storage, the higher the likelihood it's going to survive a cold winter, a period of starvation, whatever it may be. And for most of human history, that would apply. Again, if you were like living 500 years ago, you were using your body a lot more often, food was not as readily available, so storing calories was to our advantage. Now our bodies are still primed to do so, but we never have to tap into them. So even after the sleeve and after the resetting of the metabolic set point, you can put weight back on by constantly exceeding your caloric needs, constantly giving the body more calories than it needs to burn, and the body's going to be primed to do what it always does, which is store them up for a rainy day, store them up for the period of starvation. So in my mind, the key here is before surgery, you've obviously deviated this set point up and you need help resetting it. After surgery, you've effectively reset it, but if through no fault of your own or through self-sabotage, whatever you want to say, if you've slowly deviated the set point up once again, then you need help resetting it down. And unfortunately for me, doing so without another major shock, i.e. a surgical reintervention, is very, very unlikely. So it's almost better to accept, hey, I was at 300, I got down to 150, I loved it at 150, now I'm at 180, shit, how do I get that 30 pounds off once again? If you better just accept 180 is where you're going to stay.
So a pouch reset, the old pouch reset is...
Well, a pouch reset is just a diet.
Yeah,
right?
basically it's a diet. It's getting you back under control, creating a control to avoid that self-sabotage, right? Because we have a routine being going to McDonald's on the way to work,
Yep.
and participating in the group functions at lunch, and then now we have a big family dinner that I have to cook, and then I'm tasting, and then I'm still eating the pasta and everything like that. So that's the routine. But now if you say pouch reset, right, which is 2 shakes and a meal, or what I like to do is 2 shakes and 2 meals considering the restriction, it is creating a control for you to step away from the fast food on the way to work, and your ability to say no to your coworkers when you have that big lunch, and then the dinner because you have a plan and a goal.
So what you're saying is most of that pouch reset is
Just getting back on track.
and mental.
Yeah.
It's almost all mental.
Right.
Yes.
And again, let's say you're at 180, you start a pouch reset. Well, a pouch reset is a significant caloric restriction.
Yes.
And so you might go from 180 to 170, but guess what? The moment you stop the pouch reset, you'll probably be back to 180, which is fine. Again, the goal here, guys, is not if you've self-sabotaged and you've put some weight back on, the goal is not necessarily to get the weight off once again, because I feel like that is very unlikely. The goal is to not sabotage further.
Yes.
It's to not gain more weight.
Yeah, and setting something up like a pouch reset or calling it something else. But what you're saying is you have structure and ways to say, no, I'm not going to partake in that meal tonight, but I'm going to join you and enjoy the company.
Yes.
So it's really almost resetting your mind.
Right. And again, if you're starting at 300, you get down to 150, you find yourself at 180, well, I can almost assure you that you're not eating healthy more often than not. And that's why you're at 180. And if you start eating healthy more often than not, you'll stay at 180 instead of continuing the behavior that got you 180 in the first place, and then a month later or a couple months later you're at 190 and then 200 and so forth. Remember, guys, you've got a tiny stomach, but if you're eating too many calories every single day, your body will store the excess, and slowly but surely the weight comes back on.
Yeah, it is difficult to stretch out your stomach, but very easy to eat more calories.
Yes.
Right.
Correct.
So talk to us a little bit about an additional intervention. We predominantly do our safe sleeve on somebody who has not had weight loss surgery before. However, we are one of the first to really focus on the SIPS procedure.
Yep.
I'd like you to talk a little bit about what is the SIPS procedure and who is that meant for? Because it kind of ties into exactly what we're talking about now.
So here's what it comes to. I never start someone off with the SIPS as the index operation because I need it as a salvage operation for those that need a second chance. Some people will make mistakes, and some people need to learn the hard way through screwing up their chances with the sleeve. But it's unheard of to screw things up twice. Every single patient that I've ever done a sleeve to SIPS on has been like, holy shit, I just need a second chance. Is there something we can do? And the answer is yes. You can go from the sleeve to the SIPS. Once you got the SIPS, nobody makes the same mistake because they've already learned from it. They're already like, oh shit, I had one chance. I screwed that up. Thank God I have another chance. I ain't screwing this one up. Okay? But if you start with the SIPS and you learn the hard way that time around, again, once you've got that aggressive of an operation,
There's almost
little
nothing
other
to do next.
There's nothing. I mean, again, there's nothing more aggressive than that.
Really, nothing you can do.
Yeah.
So for me, the vast majority of the patients will lose the weight and keep it off with the sleeve. For the rare patient where something happened, someone in the family died, they got fired, they got laid off, like certain stressors in life are unavoidable. And if those stressors are kind of the nidus for rapid weight regain or slow gradual weight regain over the course of months to years, again, everybody deserves a second chance, okay? You can't condemn someone and say, hey, through no fault of your own, the sleeve didn't work out and you're screwed, okay? So whether it's because something in life happened that, you didn't get your fair shake at things and the weight came back after the sleeve, or because you screwed it up, you weren't ready, you self-sabotage, you went back to your old habits and the weight came back, either way, the second chance is always the last chance someone needs. And the difference between the restrictive sleeve and the malabsorptive SIPS is you're basically now in a situation post-SIPS where you're eating, but you're not absorbing nearly as much as you're consuming. And so that's the second oomph you need to not only lose the weight, but as we started talking about at the very beginning of this, once again, reset the set point.
So tell us in layman's terms, not scientific doctor speak, what are you doing in a SIPS?
So basically, you cut the end of the sleeve and you reconnect it further downstream in the intestines. So the intestines are a one-way conduit. And so right now, you eat, they go into the sleeve, and then the food and the nutrients enter the very beginning of the intestines, and you have all of your intestines to absorb everything that you've consumed. Okay? With the SIPs, you plug in about halfway, and all the upstream stuff, because it's a one-way stream, never sees nutrients. And so it's only from that midpoint downward where the nutrient absorption occurs. And because there's less time in the intestines and there's more quicker intestinal transit, you eat and more comes out the other end than you're used to, and more calories are not absorbed, and you're in a more of a caloric deficit. So to make it overly simplified, imagine you currently consume 1,500 calories with your sleeve. Okay? 1,500 consumed, and because you've got all your intestines at play, 1,500 is absorbed. If you need 1,200 calories per day, and you're eating 1,500 calories per day, you're in a 300 calorie excess. And that 300 calories gets stored up, and slowly but surely you're putting weight back on. Now, imagine you have the SIPs. You're eating the same 1,500 calories. Let's say roughly 900 of it's absorbed. Okay? That means 600 of it is going out the other end, meaning you're pooping more, you're having more loose stools. Again, you're getting rid of 600 calories through malabsorption every single day. Well, now you're eating 1,500, 900 gets absorbed, you still need 12. Because you need 1,200 calories and you're only effectively absorbing 900, now you're in a 300 calorie per day deficit relative to what you need. And now 300 calories is being withdrawn from your fat reserves to make up the difference. And therefore, even with the same 1,500 calories, because you're absorbing less and because you've got the SIPs, now you're in a state of deficit instead of a state of excess. So now instead of gaining weight slowly with the 1,500 calories in the sleeve, now you're losing weight slowly with the 1,500 calories in the SIPs.
So essentially, you can eat the same, but still lose weight.
Correct.
But we would still want you to make sure you are making some changes to eat the right foods.
Correct.
Because you can, we don't want you to eat pizza for breakfast, lunch, and dinner.
Correct. Well, not only that, but again, if you're eating pizza 3 times a day with the sleeve, you're gaining weight. You feel fine, but you're gaining weight. Okay? If you're eating pizza 3 times a day with the SIPs, you've got massive diarrhea, gas, bloating, terrible flatulence. Nobody wants to be in the same room as you because your GI tract with those simple carbs and those simple sugars is being, havoc is being wrought upon it. And therefore, if you don't make dietary changes, in theory, you could still lose weight with that kind of diet, but you're going to be miserable every single day in the process.
Oh, it's a tough way to live.
So for the most part, when you've got the SIPs, if you're focusing on protein, healthy fats, and reasonable glycemic index foods, the likelihood of you suffering with gas, bloating, diarrhea is quite low, and you're still losing the weight, and you haven't made major overhauls. But remember, the vast majority of our patients, it's not like they're eating terribly. Mm-hmm. They just have to offset their low metabolic needs with the fact that over time they may have dilated their sleeve a teeny little bit. They're getting a teeny bit more calories than they once were. And as we age, our metabolic requirements go down and so forth. So there's a lot of factors that can ever so slightly tip the scale from being at 1,200 calories per day comfortably to being at 1,500 calories per day is what you're consuming when you still need 12. And the difference will be putting you into that malabsorptive state without necessarily making major changes. Remember, the vast majority of patients I do the SIPs on, they're eating pretty well. They're just getting a teeny bit more calories in than they need. And over the course of years, those teeny bits of extra calories are adding up to some meaningful weight gain. They just need some extra oomph to not only put them into a caloric deficit, but also to help further reset the set point.
100%. But now what we do recommend in terms of nutrition intervention is required.
Oh, yes. Absolutely.
100% required. Otherwise, you will face some long-term complications in terms of
vitamin and mineral deficiencies, again, protein
symptomatic.
Correct, symptomatic. So you have to understand, guys, this small bowel is like a long river, and each point along that river is specialized at absorbing certain things. So when you skip the upstream part of that river, and now all of a sudden food's only entering downstream, all the upstream stuff that's better suited at absorbing iron, vitamin D, and so forth, it's not seeing the food stream anymore. And so you've got to bathe the remaining intestines with the supplements on a daily basis so that even though those aren't the ideal locations for absorption, it still absorbs some. You just have to deliver plenty to offset the fact that that's not where the preferred site of absorption is. Correct. So not taking your vitamins and minerals and supplements as prescribed after a SIPS is terrible and tragic.
Wow.
You are better off staying at, if you, let's say you started 300 pounds, you got the sleeve, you got down to 150, and life happened, and 5 years later, you're back up to 300. You're better staying at 300 if you're not going to take your supplements than you are getting back down to 150 and running into the guaranteed vitamin deficiency that will inevitably happen if you're not taking your supplements on a daily basis. Symptomatic vitamin deficiencies are terrible and tragic and completely avoidable when you take your supplements as prescribed.
Mm-hmm. Interesting. So you just talked a little bit about who's not a candidate. If you're not willing to supplement for life post-SIPS, this is not something you should consider.
Correct.
But talk to us about who is a candidate. So somebody obviously who maybe was successful on the sleeve but didn't lose as much as they wanted to, or sabotaged a little bit, maybe through no fault of their own. What other types of requirements do you look for in a SIPS candidate?
So for the most part, it's either someone who has lost all the weight but gained it back for one reason or another, or who didn't lose all the weight in the first place. Mm-hmm. And usually the second category is someone who, again, if you're starting off at 390, even if you're losing 15, 20 pounds a month for 6 months and like another 10 to 15 for the next 6 months, depending on your height, you might not get all the way there. You might not crack 200 in a year if you're starting at 390. And so if you're at 200, but your ideal body weight's 110, well, guess what? You busted ass. You got the full power out of the sleeve. You lost 190 pounds, but still at 200, you're like, oh man, I still have 90 pounds to go. But the metabolic set point kicked in. You're a year out. That golden period's gone. And now your choice is either stay at 200, which is certainly better than 390, or consider a second stage to get that last 90 pounds off. Okay? But the key here is I need someone who is certainly not a smoker, certainly not on medications that will be unlikely to be no longer necessary after the weight loss. If you're on a bunch of medications and they're not weight related, the absorption profile changes. And so it's not necessarily a deal breaker. There are certain medications that we can change up from immediate release to extended release. We can up the dosage, but there's more intensive upfront legwork required between myself, the PCP, the psychiatrist, whatever it is, to make sure that the patients don't start withdrawing from these kind of medications once they're put into the malabsorptive state. So the ideal candidate is non-smoker, compliant with taking their supplements, needs to lose a good amount of further weight, whether it's weight regain or suboptimal weight loss, isn't on medications that they'll still have to be on once they've lost the weight. Again, if you gain the weight back and your blood pressure is back and your diabetes is back and your cholesterol problems are back, hey, guess what? You lose the weight again, those things go away. You don't need the meds anymore. Who cares? Okay? So, and then of course, the other consideration here is with the sleeve, we're in the left upper quadrant for the most part. So surgeries elsewhere rarely impact our ability to get the sleeve done. With the SIPS, we're in the right lower quadrant, we're in, kind of like the mid-abdomen, we're in the left upper quadrant, so we're all over the place. So if you've had open surgeries before, the likelihood of getting the SIPS done laparoscopically is lower than it would be if you've had nothing but laparoscopic interventions or you've had no surgical interventions except for the sleeve. So that's one thing to consider. And then the other thing to consider here is if your pre-existing blood work, I check full labs on everyone. If you're terribly anemic and you're using all your intestines currently, putting you into a malabsorptive state and skipping that prime first portions of the small intestine that absorb the iron, it might not be in your best interest if we can't get the anemia resolved before we put you into that malabsorptive state. So there's a lot of stuff that kind of goes through my head when it comes to how someone looks on paper and current problems and current medications and how those things will be affected by the weight loss. So for the most part, the easiest thing is just pick up the phone and call. Again, absolutely. Everyone that works here knows kind of like the red flags. There are certainly deal breakers. No, can't get a SIPS from our program. Those that pass the initial set of screening questions, they get their labs. Then I meet with them. We kind of talk about pros, cons, risk, benefits. And again, the surgery works tremendously well. Everyone that goes from sleeves to SIPS loves it. But it's just a matter of Does the patient know what they're getting themselves into? Is the patient willing to accept the lifelong supplementation requirements? And are they ready to make the commitment and get the second chance that they seek?
100%.
That's good.
And making sure that, labs are good. And,
Yep.
and even, that's not even necessarily a deal breaker if everything else checks off, because you can fix that.
Correct.
Right? Through intervention with supplementation.
Correct.
What you should have been doing in the first place.
Correct. If you haven't been taking your supplements for 2 years, we check your blood work and you're deficient in D, you're a little anemic, you've got, some low folate, whatever it is. Well, guess what? You talk with Alex, he tells you what to start. You start taking everything every day like you're going to have to after the surgery, and then we check whatever you were deficient in a month. Odds are you're not deficient because you're not absorbing it well. Odds are you're deficient because you weren't getting enough of it.
Exactly.
Once you start delivering enough of it to your normal intestinal stream, then everything normalizes, and then you're good to take the hit once we put you into the malabsorptive state. But for me, if I can't get your labs corrected with aggressive oral supplementation pre-sips, I won't do a sips on someone like that, because I don't want to subject someone to the need for IV supplementation after surgery for the rest of their life. So again, it's rare. It's rare when someone with enough increasing dosage of oral supplementation can't get their labs normalized.
We've corrected so much.
Correct.
There were so many patients actually who have had deficiencies.
Oh,
in
it's
certain
rare when
things,
they're
and-
perfect.
Yeah, it is. It's rare
It's
when
rare when their
perfect.
labs
We're
are normal
talking
when they
about
consider the process.
a couple months.
Correct.
A couple months of intervention with supplementation, and it gets corrected once you get your blood work done again, which is
Correct.
fantastic, and then they can move forward.
Yep.
So the process as far as scheduling for SIPs is a little bit different. I'll review that again. But the experience once you get here is that Blossom experience that everybody understands. If you've been here already for your sleeve, like Dr. Apel said, you're here for 4 consecutive appointments. And then you're back to, hopefully getting right back into normal life with some limitations. So again, the SIPS process is the same. We take care of your transportation. We take care of you, your hotel stay. And you are here for 4 consecutive days. The appointment layout slightly different. We don't need to get into that now. But to go back to what that kind of qualification and intake process is, obviously starts with a phone call. If you want to get a jump ahead and you're really serious about a SIPS revision, go get those labs today. You can even call the office. We'll tell you exactly what we suggest.
Start taking your supplements too.
Start taking your
that's
supplements
correct.
now.
Exactly.
But that's where the process differs a little bit. So if you were to call the office, one of our amazing gals on the phone would kind of screen you a little bit, ask some basic questions.
Yep.
At that point, ask the doctor, is this a person a candidate for SIPS? It would either be a yes or no, but obviously the very first thing required, no matter where you're at in the process, is getting those labs done.
Correct.
So let's say you got those labs done, you send them to our office, we would then set you up with an e-visit, most of the time with Dr. Apel, sometimes with Alex, sometimes with both. If you review something and you see, okay, you're deficient in this, yes, you'd be a great candidate, but we need to do some supplement intervention.
Correct.
That would go over to Alex. You'd have a conversation with him. He'd tell you exactly what you need to do. You'd be on track, with that intervention for how long? Or does it depend?
It depends on how deficient you are to begin with. If your vitamin D is 9, well, shit, we got a few months to work with this, okay?
Definitely.
If your vitamin D is 27 with aggressive supplementation, odds are you'll be within normal, low limit of normal within a month. But again, the key here, remember, guys, is I'd rather have everyone who's getting the SIPs on the higher limit of normal to begin with when we pull the trigger for the surgery, so that there's a bit more buffer for us to get the surgery and allow there to be a bit of a drop as a result of the malabsorptive state without it getting critically low or symptomatically low. So for me, if the normal vitamin D range is 30 to 100, if you're getting surgery at 80, you've got room to take a hit, and then we see the hit on the labs at 3 months, and we can reintervene and get things to go back up before it gets below 30. But if we're pulling the trigger at 32, and you take the same hit you do post-operatively at 3 months with the malabsorptive state we're going to put you in, well, you go from 32 to 15, that's worse than going from 80 to 65.
Right.
So for me, I want you to aggressively supplement pre-op, bulk up your reserves, get things back in storage, so that when we put you into the malabsorptive state, you can afford to take a bit of a hit without it becoming a concern.
And this is where the bariatric multivitamin is highly recommended, because those vitamins and minerals that do take a hit are the ones that are elevated in those vitamins. So keep that in mind.
Correct. And the other thing here, just to think about kind of globally, I love tooting my own horn, so I'm going to do so right now. Our safe sleeve operation is incredibly safe. We've never had a leak on a virgin sleeve. The likelihood of bleeding is incredibly low. Like, our number and our safety profile with the safe sleeve is second to none in the country / the world. Okay? So choosing us for the sleeve operation is obviously a no-brainer. Choosing us for a sleeve to SIPS is of even greater import because this is a much more specialized procedure that requires bariatric training, years of practice, many hundreds of procedures under your belt to become really, really, really good at this. So if you're getting the SIPS from someone who doesn't do them on a regular basis, then it's like getting your special car treated at Jiffy Lube instead of taking it to the dealership and getting it done because you got a special high-performance vehicle. Just makes no sense. Again, guys, we are the go-to place for the safe sleeve operation. If you want to have the highest likelihood of getting the surgery, coming here, going home, and getting back to normal life with the lowest chance of a complication, we're your bet for the safe sleeve, and we're certainly your bet when it comes to sleeve to SIPS.
Absolutely. Is it true too that the sleeve to SIPS post-op, now I'm talking in the hours, in the days, in 3 to 5 days afterwards, is an easier recovery?
Yeah, because the bulk of the nausea that you experience with the sleeve is no longer an issue because you already got the sleeve. We don't touch the sleeve. You've already got the sleeve. We just do the second part of the operation, which is doing the switch, or kind of the quasi switch, putting into the malabsorptive state. So you'll still have the discomfort from the gas. It's usually less, and you'll have odds are you'll have much less nausea. So the bulk of the SIPS when I see post-sleeve patients on day one, most of them are like, oh my God, I feel so much better. Yesterday was terrible. When I see post-SIPS patients on day one, they're like, oh, yesterday wasn't bad. Today I feel fine. And I'm already drinking 40 to 60 ounces. And that's like the norm. That's not the exception. That's the norm.
And introducing foods a week out.
Correct.
It's so much.
I don't want you on liquids for 2 weeks because you're going to be in the toilet all the time. I want you on liquids just enough time to let the anastomosis kind of get that initial healing underway. A week later, you can start going to softs. A week after that, you can start going to solid foods.
Yep.
That's great.
And again, the weight loss trajectory here, guys, is phenomenal. The sleeve, like we talked about, is great for the vast majority of patients. It's the lower risk operation that gets most people where they need to be and keeps them there. In the event you need the second stage or in the event you need a second chance, the sleeve to SIPS is a great operation, and it's more of a marathon than a sprint.
Yes, we're not worried you're not going to lose weight. It's the nutrient deficiencies that we're worried about.
Correct, which is why we don't do that as a primary operation. If we did the SIPS on everyone as the index operation, then yes, we'd have a bunch of people losing everything they need, but we'd also have a bunch of unnecessary vitamin, mineral, symptomatic deficiencies, a bunch of people with quasi-dumping, a bunch of people with some potential downside from overdoing it in the SIPS with too many individuals. So with the proper patient selection and those who already have the sleeve, again, number one, you don't screw it up a third time, and number two, the right individuals are being chosen because they've already proven that they have either gained some weight back or not lost all of what they sought to lose in the first place.
If anything, it's like that's qualifying,
Correct.
Right? Is going through the sleeve process.
That's what helps sift those that will benefit from the sleeve in the first place and benefit from the sleeve alone versus those that will ultimately need the second chance.
Yeah, that's great. So we talked a little bit about obviously the qualification process, the scheduling process is a little bit different, but also is the post-op visit process. So again, with our initial safe sleeve procedure, you're going to your primary care at 6 and 12 months, and at least every year, but twice a year thereafter. With the SIPS, a little bit different because we do follow up with these folks. So we're doing more frequently.
Yes.
So that is 3, 6, 9, and 12 months.
Then 18, then 24.
Right.
And again, like we talked about earlier, plus or minus the blood work, plus or minus the supplements with the sleeve. Again, there's some debate. You can have an active academic conversation about that. There is no debate when it comes to the frequency of the blood work and the need for aggressive, lifelong, daily supplementation with the SIPS. And the reason that we check the blood work so often is to make sure that you don't get to the point where you're in a symptomatic deficient state.
Right.
Okay? Again, symptomatic vitamin deficiencies are tragedies. They're completely avoidable, which is why you need your blood work at 3 months. Almost everyone, even if their blood work's perfect before surgery, we're putting you into a very aggressive malabsorptive state. Even if you're taking the supplements the exact same way after the SIPS at 3 months, odds are things are going to start trending down. I mean, that's the nature of what we're putting in. You're losing weight. You're not absorbing calories as much. You're not absorbing supplements as much, which is why at 3 months, we got to say, aha, D is trending down. You need more D every day. Aha, zinc is trending down. You need more zinc every day. Aha, A is trending down. You need more A every day. And then we check it at 6 months, and we see if the additional supplements are enough to keep things stable and build things back up. Remember, I don't want things to climb up. I don't want things to climb down. I want to find what it takes to keep you in a steady state. And I can do so if we have labs at 3-month intervals for the first year. After a year, again, the odds are we'll keep you at that steady state, which is, and I just double check at 18 months, triple check at 24 months. And then once a year, we get your blood work just to make sure that the regimen that we've come up with in that first year or two continues to be the regimen you need to keep your levels normal.
And it's not even just the supplements as well. It's the actual food intake,
Yes,
how
of
many
course.
calories, the protein, and the balance from that too. Because yes, you can be deficient in vitamin D, then you're doubling vitamin D, tripling vitamin D, and it's like, okay, well, where's the disconnect? Is this just bad vitamin D? It's like, oh no, it's a fat-soluble vitamin. We need
Correct.
to actually increase your fat intake to
Correct.
absorb vitamin D.
Yeah.
Right.
And then things like that as well. So, and
So those are
that's
the
what's happening.
conversations that you can expect at the 3, 6, 9, 12. And
Correct.
who doesn't want to just talk to you guys? Like
Yeah,
every month?
right,
I mean,
exactly.
And so these are virtual discussions. You don't have to physically be here. So the SIPS is available for anybody in the world or anybody in the US who fits that criteria that we kind of touched on.
Yeah,
Correct.
we do the e-visits, the Zoom conferences, things like that too. Schedule it at your convenience, and that's how we have our discussions. Or phone call if you don't like to be
Yeah.
if you don't like to be seen.
And a couple real quick things I want to note too. So this is not covered by insurance. This is 100% self-pay at this time.
Yep. Because it's a new procedure that's not yet been completely adopted like the duodenal switch. Now, again, the duodenal switch is a great operation, but it is very risky. There's a 30% complication rate. 30% is kind of high. The SIPS is a modification of the duodenal switch that allows the weight loss profile to be very, very, very similar. So you get to keep all the upside, but the risk and complication profile is much, much less. So you eliminate the bulk of the downside. But as insurance companies are apt to do, they want to save their money, just like they're trying to disqualify patients by putting a bunch of hurdles and hoops to jump through to get the sleeve. So too do they do it with procedures that have not yet been around for 30 years. The SIPS has been around for 10 plus.
What is the biggest difference between the SIPS and the duodenal switch?
The number of new connections, how much is being skipped, the complexity of the operation. So again, you want a surgery. The ideal surgery here is lose a bunch of weight, lowest complication rate, both from the surgery itself and lowest long-term complication rate from what the surgery is doing. And the SIPS is kind of that balance between getting the power you seek for the weight loss and at the same time exposing you to much lower risk, lower than the gastric bypass, and certainly lower than the duodenal switch.
Wow.
Yep.
That's awesome.
That's great.
I love that.
So if you're considering SIPS, you want to know more, maybe think you're a candidate, call us. You can call just 855-BLOSSOM, or you can visit our website, blossom.com, and have a conversation with one of the folks that answers the phone and see if that makes sense for you.
Correct. Yep.
Yeah.
It's exciting. Awesome.
Anything else you want to add?
Can we just keep going for like 2 more hours? No, I'm kidding.
Yeah, it's
that was great.
For a while. Is there anything, top tips, patients are struggling, or get a procedure done? What are your top 2?
Again, for me, the key here is this, guys. If you are on a constant roller coaster of losing weight, gaining back, losing weight, gaining back, losing weight, gaining back, and you're tired of it, the surgery isn't right for you. But you have to have been on the roller coaster. You're much less likely to succeed if you've never tried anything and your go-to is surgery. Because, again, if you're in that state of mind where you've never tried anything, you're like, oh my God, I got to lose weight, I'm going to get surgery. You've not yet struggled. You've not yet sacrificed. You've not yet had the ups and the downs and so forth. You need that in your history to succeed with the sleeve. And then once you succeed with the sleeve, if you don't, if life throws something weird your way or for some reason you've self-sabotaged, whatever it is, the SIPS is a good salvage operation and nobody screws up a third time. So that second chance is what everyone needs. I've never had a SIPS patient not do well, but it's because I only do the SIPS as a salvage operation, never as a primary operation. I know other people from other programs that have squandered the opportunity because they got the SIPS as the index operation, which is why I don't do it, because there's no third chance.
Right.
Okay? But again, for the most part, the key here is you're trusting us. It's not the surgery that does it, it's how you use the surgery and the prescription we give you in terms of how to use it well. So you get the global rules. If the body's responding as we would predict, you're cool. If the body's not responding as well as we'd predict, or if you're looking for it to respond better, there's always fine-tuning and some detail-oriented digging that we can do to figure out how to make the sleeve work better for you. But it's just a matter of helping us help you.
I love it. That's great. Anything else you want to add?
That's good. I think the last thing I want to add too is kind of piggybacking what you said about making sure that this is not just something somebody rushes into and they kind of have to have those struggles to make sure that this is the right next step. I think from like my marketing perspective, it's so important for people to do their research.
Yes.
If Blossom is the very first place you call, that's great. But please continue to do research in other clinics, other facilities, because the nature of our program is so unique. It's so different. We do things differently. If you're using your insurance, like we talked about in the beginning of this thing, it's just different the way we do it. Our workup is different. Our qualification process is different. The moment you get to Las Vegas, the moment you walk in our doors, we promise that we're going to treat every single person like our family member, like they are our special best friend. But we are unique. So I really want people to do their research and make sure they are exhausting all options. And when they do finally make that call to place their deposit, to get their surgery scheduled, that they feel like this, I know that this is the right decision.
I love that.
Yep.
I love that 100%. Good. Do your research. And when we see you, we'll take good care of you.
Exactly.
Yes.
All right, Doc. That was awesome.
Perfect.
This was great. I had
Thank you.
fun. Did you have fun?
Of course.
Yes. Let's do it again, man.
That's right. We'll do it every day.
Perfect. All right, guys. Well, that's it. If there's any other questions, please jump online or give us a call. Shoot us an email if you do have questions. If we've already had surgery or if you are considering the SIPs. Catherine, want to hit with that number?
Call us, 855-BLOSSOM or 855-256-7766, or you can visit blossom.com.
Blossom.com. All right, guys. We will see you in the next. Peace.
This was another episode of the Blossom Podcast. For more motivation and future episodes with Alex, make sure to subscribe so you don't miss out on any life-changing moments.